Uro Surgery Part 5 Willem's tumor or nephroblastoma. Origin arising from the embryonic nephrogenic tissue. Incidence the most common renal tumor in childhood, 10% of childhood malignant tumors, and 80% of all genitourinary cancers in children in less than 15 years of age. Peak incidence 3 to 4 years, 90% occur before the age of 7. Male to female ratio is 1 to 1. Pathology gross appearance appears as large, gray, sharply demarcated, apparently encapsulated mass. Areas of hemorrhage and necrosis. Renal pelvis invasion is late. Bilateral tumors are present in 5 to 10% of cases. Microscopic picture consisting of mixed epithelial, primitive glomeruli and tubules, and connective tissue, cartilage, fat, smooth or striated muscles. The degree of differentiation varies from favorable histology FH to unfavorable histology UH, where there are marked variations in nuclear size with hyperchromatism and excessive mitosis. Staging Stage 1 tumor limited to the kidney and completely excised. Stage 2 tumor beyond the kidney and completely excised. Stage 3 residual tumor. Stage 4 metastasis, and Stage 5 bilateral tumors. Clinical picture an abdominal mass. The main presentation is 90%. Character smooth, firm, and confined to one side of the abdomen. Vague abdominal pain in 1/3 of the patients, often associated with minor trauma and hemorrhage within the tumor. Microscopic hematuria in 50% of cases. Hypertension in up to 60% of cases. Cause encroachment on the blood supply leading to renal ischemia and excess renin production. Differential diagnosis neuroblastoma, childhood tumor which simulates nephroblastoma, forming irregular tumor which cross the midline. Renal swellings, the commonest is hydronephrosis as a result of congenital pujo. Investigations CBC, liver and renal function tests. Urine catecholamines normal and they are elevated in neuroblastoma. Imaging ultrasonography, the initial study of choice. It differentiates solid renal masses from hydronephrosis. It detects small tumors and liver metastasis. CT scan differentiates cystic from solid masses, detects involvement of adjacent structures or the other kidney. Follow the tumor response to chemo and radiotherapy. Chest X-ray to detect metastasis. Treatment surgery for operable tumors, radical resection of the affected kidney. For large unresectable lesions, preoperative chemotherapy usually shrinks the tumor and so they can be removed. Remaining tumor in nodes or adjacent tissues should be marked with surgical clips to facilitate direction of the radiotherapy. Post-operative treatment, if there is no residual tumor, adjuvant chemotherapy using actinomycin D, vincristine, and adriamycin. If there is residual tumor, radiotherapy is added. Surgical excision remains the cornerstone of therapy in all children with Willem's tumor. Prognosis multimodal therapy improved the overall 5-year survival to 80%. Early cases are usually cured, and the younger the child, the better is the prognosis. Tumors of the renal pelvis, transitional cell carcinoma incidence accounting for 7% of the renal tumors. Predisposing factors, cyclophosphamide, smoking, the main cause, increasing its risk up to 4-fold. Exposure to aniline dyes for workers in petroleum and rubber industries. Squamous cell carcinoma of the renal pelvis. It occurs on top of leukoplakia, often associated with infection and calculous disease. It forms a nodular ulcerated mass which invades the parenchyma. Surface implantation doesn't occur. Clinical picture hematuria, and in late cases severe pain due to extrarenal spread, and it has a poor prognosis. Returning again to the pathology of the transitional cell carcinoma, origin, it arises from the transitional epithelium which lines the renal pelvis, ureter, and urinary bladder, collectively called urothelial tumors. Grade, it's variable from low grade to highly anaplastic malignancies. A patient with a TCC or transitional cell carcinoma of renal pelvis is likely to develop same lesion in the ureter, bladder, or contralateral renal pelvis because of transluminal spread of shed malignant cells and multicentricity of this neoplasm. The whole urothelium is predisposed to malignancy by a certain carcinogen. Clinical picture, gross or microscopic hematuria in 90% of cases. Obstruction causes renal pain and or swelling, hydronephrosis. Investigations, IVU or intravenous urography showing fixed irregular radiolucent filling defect or non-visualization of part or all of the collecting system. CT scan differentiates renal parenchyma from renal pelvic tumors, and it can visualize lymph node deposits, cytology, microscopic examination of urine for malignant cells, flexible ureterorhinoscopy. A flexible endoscope is introduced from the bladder to inspect the whole upper tract. Any lesion is visualized and biopsied. Treatment: the classic therapy is nephroureterectomy with excision of adjacent cuff from the bladder. Nephroureterectomy has two indications: TCC of renal pelvis, transitional cell carcinoma, and renal tuberculosis if the kidney is too damaged to respond to anti-tuberculous drugs. And then we have urinary bladder cancer. Incidence: the commonest malignancy in Egypt. Male to female ratio 4:1. The commonest urological malignancy in Egypt. Peak age incidence between the 4th and 5th decades. In the past, squamous cell carcinoma accounted for the vast majority of bladder cancers, but currently, transitional cell carcinoma is the commonest. Classification: according to histological types, we have squamous cell carcinoma, transitional cell carcinoma, and adenocarcinoma. Predisposing factor: for squamous cell carcinoma, bilharzia squamous cell carcinoma occurring on top of long-standing bilharzia cystitis that is complicated by secondary bacterial infection. Exact carcinogenesis mechanism is not known. Non-bilharzial squamous cell carcinoma occurs with long-standing bladder irritation, which is complicated by secondary bacterial infection, as in long-standing bladder stones. Transitional cell carcinoma, similar to the transitional cell carcinoma of the renal pelvis. Cigarette smoking, the most important risk factor, increasing the risk fourfold. Industrial carcinogens such as aniline dyes, petrol, leather, rubber, and textile industries due to exposure to aromatic amines. Cyclophosphamide, chemotherapeutic drug, 9-fold increase in the risk. Pelvic irradiation, 4-fold increase in the risk noted in women treated for cervical malignancy. Both squamous metaplasia and leukoplakia are precancerous lesions for squamous cell carcinoma. Pathology: alterations of the urothelium. Squamous metaplasia: the normal transitional epithelium is replaced by mature, non-keratinizing squamous epithelium. Leukoplakia: mucosal, well-defined, thick and raised white patches. Microscopically, there is squamous metaplasia and marked keratinization with cellular atypia and dysplasia. Squamous cell carcinoma and transitional cell carcinoma. Regarding gross appearance, the squamous, nodular, solid mass, or malignant ulcer on top of a large mass, fungating mass, may arise from any part of the urinary bladder, while the transitional cell carcinoma, the common sites are the base, trigone, and around ureteric orifices, may be single or multiple, forming papillary villus growth. Microscopic appearance for the squamous, composed of keratinized cells showing features of malignancy as hyperchromia and multiple mitosis, and usually containing concentric aggregates of cells that are called squamous spirals, cell nests. But for the transitional, composed of multiple layers of transitional cells showing features of malignancy, stage of carcinoma in situ, malignant TCC cells without basement membrane invasion. Spread: direct, lymphatic, and bloodborne. Direct to the wall of the bladder and then may infiltrate adjacent organs as seminal vesicles and prostate in males or vagina in females. Lymphatic to iliac lymph groups, and bloodborne, common with TCC but delayed with SCC, common with transitional and delayed with squamous. According to degree of cellular differentiation, transitional cell carcinoma is classified into grade 1, 2, 3. 1. Well differentiated, 2. Moderately differentiated, and 3. Poorly differentiated. T and M staging: for primary tumor, TIS, carcinoma in situ, T1, invading lamina propria, 2, invading muscular layer, 3, perivesical layer, and 4, surrounding structures. N, regional lymph nodes, N0, no lymph node metastasis, and 1, lymph node metastasis. M, distant metastasis, 0, no distant metastasis, and 1, distant metastasis. Diagnosis: hematuria, the earliest symptom in transitional cell carcinoma. Character: painless, intermittent hematuria. Dysuria with recent exaggeration of cystitis. This is with squamous cell carcinoma. There's burning micturition, frequency, and pyuria. You need to know that early diagnosis is with transitional cell carcinoma, while late diagnosis is with squamous cell carcinoma. Necroturia, the passage of pieces of whitish tissue occurring in large necrotic tumor. Signs of renal failure if tumor invades both ureters, back pressure on both kidneys. Manifestations of distant metastasis in advanced stages, such as bony aches secondary to bony metastasis. DRE and bimanual examination detects presence of bladder mass and can assess size, site, and tumor mobility. Investigations: IVU, the tumor appears as an irregular filling defect. Abdominal ultrasonography, assessing bladder mass. CT scan, the best diagnostic tool for preoperative tumor staging. Urine cytology, very useful in patients presenting with CIS or high-grade TCC. Cystoscopy and biopsy, the definitive diagnostic tool. Treatment: squamous cell carcinoma and transitional cell carcinoma. Squamous cell carcinoma by radical cystectomy. Squamous cell carcinoma is resistant to chemo and radiotherapy. There is no rule for partial cystectomy. In males, resect the whole bladder with its perivesical fat, prostate, seminal vesicles, and lower ends of both ureters in one mass, while in females, resect urinary bladder, uterus, tubes, and anterior vaginal wall. In both genders, block dissection of internal and external iliac and obturator lymph nodes. Urinary diversion is then performed. Flap of ileum is transformed into the urinary bladder. Transitional cell carcinoma, superficial TCC, TIS, and T1. Depth of infiltration doesn't reach the muscular layer. Transurethral resection of the tumor, TURT. Exercise the tumor with underlying muscle plus multiple random biopsies to detect carcinoma in situ, regular checkup cystoscopy for 5 years to detect recurrence, or post-operative intravesical chemotherapy and immunotherapy by BCG vaccine used to prevent recurrence, radical cystectomy in cases with multiple recurrences, muscle invasive TCC T2, 3, and 4, radical cystectomy, similar to that of the squamous, radiotherapy, reserved to those unfit for or refusing surgery as results are inferior, chemotherapy for metastatic disease or those with positive surgical margins, combination chemotherapy formed of methotrexate, vinblastine, adriamycin, and cisplatin, MVAC, is the standard protocol for TCC. Urinary diversion following cystectomy. Choice of method depends upon condition of the patient and surgical experience. Ureterocolic anastomosis operation. The two ureters are anastomosed to the sigmoid colon. Advantage: simple, rapid, and the patient is content. The disadvantages are recurrent upper UTI, deterioration of renal function, absorption of chlorides in urine by colonic mucosa leading to hyperchloremic acidosis, hypokalemia, formation of ammonia from the urea in urine, leading to encephalopathy if the liver function is compromised, development of cancer colon in 30% of cases after 10 years. Ileal conduit operation. Segment of terminal ileum is isolated with intact blood supply. The two ureters are implanted in the ileal segment. At one end, the ileal segment is closed and fixed at the other end to the skin as in ileostomy. We have special appliance is applied to the ileostomy to collect urine. At this type of diversion is non-continent. Advantages: ascending infection and renal function deterioration are less common than with ureterocolic anastomosis. Rectal bladder operation. The sigmoid colon is divided above the rectosigmoid junction. The proximal end is brought out as a colostomy. The distal end is closed and the two ureters are implanted in rectum, which will now work as a urinary bladder. Advantages: the patient will usually be continent for urine there and no hyperchloremic acidosis. The main disadvantage: the presence of permanent colostomy. Continent orthotopic urinary diversion. The standard urinary diversion nowadays whenever feasible, as it preserves the normal pattern of urination. Operation: separate a segment of bowel with intact blood supply, change its configuration from a tube to a sac so that it can accommodate and store urine. The ureters are implanted in the new bladder and the base of the new bladder is anastomosed to the urethra. Prognosis: 5-year survival for superficial TCC treated with TURT ranges between 72% and 90%, depending on the tumor grade at the time of initial diagnosis. On the other hand, muscle-invasive tumors managed with radical cystectomy have 40 to 50% survival rate, and for stage T2, which drops below 30% for advanced cases. Prostate cancer incidence. The most common solid organ cancer in men worldwide. The prevalence shows a constant rise over successive decades starting at the age of 50 years. Predisposing factors: family history. Relative risk is greatly increased if one or more first-degree relatives have the disease, father or brothers, Race: African Americans have the highest incidence, while Native Asian populations have the lowest incidence, and rising age. Pathology: gross picture. Origin: arising from the peripheral zone beneath the capsule. In the majority of neoplasms, 75%, the tumor appears as hard infiltrating pale nodule. Microscopic picture: 95% are adenocarcinomas. Spread: direct invasion involving the seminal vesicles surrounding tissues. The rectum is rarely invaded as fascia of Denonville acting as a barrier. Ureteric obstruction may also occur. Lymphatic spread to internal, external, and common iliac lymph nodes, then to the para-aortic lymph nodes. The obturator lymph nodes may also be involved. Blood spread to bones in 90% of cases, especially lower vertebrae, neck, femur, and pelvic bones with ribs. The preference of pelvic and lumbar vertebrae is attributed to the possible reversal of blood flow from the vesico-prostatic plexus to emery veins of the pelvic bones. Metastases are usually osteoplastic, rarely in lungs or the liver. Staging system: TNM, T primary tumor, 1 clinically impalpable tumor, 2 tumor confined within the prostate, 3 extensions through the prostatic capsule, and 4 tumor invading adjacent structures. N for regional lymph nodes: 0 no lymph node metastasis and 1 regional lymph node metastasis. M distant metastasis. M0 no evidence of metastasis, while M1 means distant metastasis. Investigations: lab, imaging, and biopsy. Biopsy guided by transrectal ultrasound to establish diagnosis. Indications: patients with suspected prostate cancer due to elevated PSA or abnormal DRE findings. Imaging: transrectal ultrasonography, TRUS, giving an idea about the extent of the lesion and used to guide biopsy. Bone scan by technetium-99m detects areas of increased bone activity. Metastasis will appear as hotspots, not specific, and any abnormality should be compared with the clinical examination and plain radiography. While CT scan of the pelvis detects pelvic lymph node deposits. Plain X-ray of the chest, pelvis, and spine may detect metastases, which are usually osteoplastic. Laboratory: PSA or prostate-specific antigen, the most useful marker for diagnosis and for follow-up. Normal value is from 0 to 4 nanogram per milliliter. An elevated level suggests prostate cancer, but may be caused by other prostatic conditions such as prostatitis and BPH. A markedly elevated, more than 20 nanograms per milliliter, suggests disseminated disease. Acid phosphatase, raised in 70% of patients with extracapsular or metastatic disease, raised in many other conditions as Butcher's disease, Paget's disease of the bones, and with breast and gastric cancer. Alkaline phosphatase, raised with bony or hepatic metastasis. Blood picture, blood urea, and creatinine. Treatment of prostate cancer depends on local extent of the disease, the presence of metastasis, and general conditions of the patient. Treatment of the prostate cancer divided into early and late. For early, radical prostatectomy, radiation, and watchful watching, while for late, TURP and hormonal treatment. Radical prostatectomy indications: early localized disease in a fit patient, operation, removal of prostate and seminal vesicles together with block dissection of obturator, internal and external iliac lymph nodes, the bladder, then anastomose to the urethra. Approach: open surgery through retropubic or laparoscopic. Complications: urinary incontinence in 5% and erectile dysfunction in 30%. Radiation therapy indications: for localized disease and for locally advanced cancer. Palliative: for symptomatic bone metastasis to relieve pain. Method and dose: external beam radiation therapy is applied giving high doses of around 70,000 GY over 5 weeks. The side effects are bladder irritation, leading to frequency, micturition, and urgency, rectal irritation, diarrhea or bleeding per rectum, and erectile dysfunction. Hormonal therapy indications: advanced metastatic cases, mainstay of the treatment for patients unwilling or unfit for surgery or radiotherapy. The rationale is that prostate cancer is androgen-sensitive tumor. Methods for androgen ablation: bilateral orchiectomy, occurs by removing the main source of androgens. Disadvantages: loss of libido and erectile dysfunction. Luteinizing hormone releasing hormone agonists such as leuprolide acetate. Action: initial rise in the level of the testosterone for 4 to 6 weeks, then a drop to castrate level. Through their effect on the pituitary gland, they give equal results to castration and have the same side effects. Anti-androgens: flutamide, Action: blocking testosterone receptors by competitive inhibition. They are used as adjuvants to castration or LHRH agonists, which is luteinizing hormone-releasing hormone agonists. Estrogens, acting as anti-androgens. Major disadvantage: predisposing to DVT, transurethral resection of the prostate, TURP, additional for advanced cases with bladder neck obstruction. Expectant management: watchful waiting for small well-differentiated tumors in elderly men, particularly if their anticipated life expectancy is less than 10 years. Prognosis: many small localized well-differentiated tumors will not progress and will not affect life expectancy. With tumors localized to the prostate, the 10-year prostate cancer-specific survival is around 75%. If metastases are present, the 10-year survival rate drops to 10%. The testis and the scrotum. Development of the testis develops from mesodermal gentle fold behind peritoneum and below the developing kidney, receives its blood vessels and nerves high in the abdomen. The testis descends downwards, pulling with it its blood supply and nerve supply and the fold of peritoneum, the processus vaginalis. Its distal portion persists as the tunica vaginalis. As testis reaches the lower part of the abdomen, it unites with some of the mesonephric tubules, giving vasa efferentia. The Wolffian duct develops the epididymis and the vas deferens. Normally, the testis reaches the scrotum just before birth. Descent of the testis depends upon differential growth of the body. Cranial segment grows faster than the caudal segment. Maternal chorionic gonadotrophins and pituitary gonadotrophic hormones. Contraction of the gubernaculum, a fibromuscular tissue extending from bottom of the scrotum to the lower pole of the testis. Incompletely descended testis or undescended testis incidence affecting 1% of all males, bilateral in 20%, commoner on the right side and higher incidence in premature birth. Predisposing factors: mechanical factors, shortness of spermatic vessels or vas deferens, or deficiency of gonadotrophic hormones. Cryptorchidism means bilateral undescended impalpable testes. Congenital anomalies of the testes are maldescent of the testis, incompletely descended testis, undescended testis, or ectopic testis, or testicular agenesis, rare, or supernumerary testis, which is also rare. Site of the incompletely descended testis or undescended testis: the testis may rest anywhere along the normal line of descent, in the abdomen, intra-abdominal, in the inguinal canal, at the external ring, or at the neck of the scrotum, high scrotal. Clinical picture: absence of one or both testes, which is usually discovered by the mother or the attending doctor, present since birth. The ipsilateral side of the scrotum is empty or underdeveloped. The testis is palpable if it lies high in the scrotum. A testis can lie in the inguinal canal and may be felt with difficulty. Testis identified by giving characteristic thickening sensation when compressed. An associated hernia may be present. Complications: depressed spermatogenesis. Effective spermatogenesis requires a temperature less than that of the body core. Testes are normally placed outside the abdomen and scrotum. An undescended testis is exposed to body temperature. It affects its spermatogenic cells. Up to 2 years, the testis remains almost normal. After that, the higher temperature leads to developmental retardation. At puberty, irreversible destructive changes in the germinal epithelium occur. Sterility occur in bilateral cases. On the other hand, hormonal function of the testis remain normal. Secondary sexual characters develop normally even in bilateral cases. Increased liability to testicular malignancy, especially in intra-abdominal type, that is genetically determined and may affect the patient even after a successful orchidopexy. Associated oblique inguinal hernia in more than 90% of cases. Increased incidence of trauma, especially in inguinal canal type. Torsion of the spermatic cord and psychiatric disturbances. Differential diagnosis: ectopic testis, retractile testis, testicular agenesis, atrophy of the testis after mumps or chitis. Hermaphroditism should be excluded in bilateral cases. Investigations: lab, hormone assay, LH and testosterone hormone to exclude anorchia in bilateral cases. Radiology, ultrasonography and CT scan to localize the site of the testis when it's not felt. Laparoscopy to detect intra-abdominal testis. Treatment: orchidopexy, the standard treatment, timing before the age of 2 years. Operation: inguinal incision is made, associated hernial sac is dissected and transfixed at the internal ring. Mobilize vas deferens and testicular vessels from surrounding. The empty half of the scrotum is stretched to prepare a scrotal bed for the testis. The mobilized testis is fixed in the scrotum to avoid retraction, commonly by placing it in a dartus pouch. created between the skin of the scrotum and the dartos muscle. Management of difficult cases. Cause of difficulty: short testicular artery. Management by stage or ketobexy. Testis is brought down in multiple stages. Microvascular technique: division and re-osmosis of the testicular vessels at the lower level to the inferior epigastric arteries. Orchidectomy: only if the upper testis is normal and undescended testis is atrophic. Ectopic testis. Pathogenesis: testis is passed out of external inguinal ring, then deviated outside normal route to subcutaneous ectopic position. Etiology: the pool of an accessory gubernaculum. The possible sites are inguinal region, most common, perineum, femoral triangle, and root of the penis. Clinical picture: empty scrotal compartment since birth. The testis is filled in one of the above-mentioned ectopic sites. The most frequent position is the superficial inguinal pouch. The hormonal and the spermatogenic functions are normal. Undescended testis. Being subcutaneous, the testis is easily felt and bulges more if the muscle contracts, while undescended testis disappears because it's usually deep in the inguinal canal. Treatment: surgical replacement of testis in corresponding scrotal compartment. Retractile testis: it's not a disease because the testis has descended normally to the bottom of the scrotum. Incidence: commonly seen in young children. Etiology: exaggerated cremasteric reflex. Pull the testis up on contraction. Site of the testis lies in the superficial inguinal pouch. Differentiated from incompletely descended testis by the scrotum being well developed, and the testis can be pushed into the scrotum by sliding fingers down the inguinal canal, especially if the child squats and draws the side to the abdomen, or if the child is examined during sleep in a warm room. Diagnosis: if testis brought down to touch bottom of the scrotum at any time. Treatment: not required. Reassurance of the parents that the condition will be cured spontaneously. And this concludes our part for the Uro surgery for today.